Hello, hello. Good morning, everyone. Myself, Dr. Shreya, Associate Professor in the Department of Prosthodontics and Crown and Bridge, EC member of the GNIDSR Alumni Association. It is my great pleasure to welcome you all to the much anticipated program, Focus 2025, the EndoEdge, Hands-on Mastery with a Global Mentor. The landmark event is being organized by the GNIDSR Alumni Association in collaboration with the Guru Nanak Institute of Dental Sciences and Research, IQAC, Department of Conservative Dentistry and Endodontics, proudly supported by the JIS Group, with Neoendo as our esteemed event partner. The Guru Nanak Institute of Dental Sciences and Research, Kolkata, stands as a beacon of excellence in dental education. We take immense pride in being the first dental college in West Bengal to achieve the prestigious NAC-A accreditation and the only institution in the state to secure our ANI-RF ranking in 2022. These accomplishments reflect our unwavering commitment to quality and innovation, guided by the visionary leadership of the JIS Group. We would like to extend our heartfelt gratitude to our respected Principal Sir, Professor Dr. Jayanta Bhattacharya, whose continuous support, academic vision, and leadership have been instrumental in fostering an environment that encourages learning, innovation, and alumni engagement. We are equally grateful to our principal in charge for today's event, Professor Dr. Shabnam Zahir Ma'am, for her dedicated coordination and leadership in making this program a success. Each year, the Alumni Association hosts Focus, an annual academic initiative to elevate clinical expertise and foster advanced learning among our students, interns, and the alumni. This year is no exception, and today we are privileged to be joined by an eminent personality whose presence marks the highlight of this event. It is now time to introduce the man of the hour, the guiding force behind today's hands-on training, a proud alumnus of GNIDSR who has taken the field of endodontics across global borders. Please join me in welcoming Professor Dr. Niladri Maiti, sir, who is currently serving as the Professor and Dean of the School of Dentistry at Central Asian University, Tashkent, Uzbekistan. A passionate researcher, teacher, and clinician, Dr. Maiti continues to lead advancements in laser dentistry, biomaterials research, and minimally invasive endodontics. Ladies and gentlemen, it's our distinct privilege to welcome back to his roots our very own Professor Dr. Niladri Maiti. Moving on, I would like to invite our respected principal in charge, Professor Dr. Shabnam Zahir Ma'am, to kindly address the gathering with her welcome speech.
Thank you, Dr. Shreya, and good morning, everyone. Respected Superintendent Dr. Soumitra Ghosh, dignitaries on the stage, down the stage, heads of the departments, faculty members, present students, ex-students, alumni members of GNIDSR, non-teaching faculty members, I welcome you all to Focus 2025. It's as teachers, Guru Nanak Institute of Dental Sciences started in 2003. So it's almost 22 years. And really we are so proud that our students are doing so well in our college, in India, and also abroad. So it's a joy and also sadness, because joy as you are growing in your profession, and sad because you are moving away from your alma mater. Sadness just like a mother that your son or your children who are growing and moving away from you but getting brighter in their professional path. Now, GNIDSR Alumni Association, every year they are organizing lot of programs like Focus, and they are organizing the alumni meet. They are organizing numerous photography competitions. They have plantation programs over here. Then they also organized Amar Shati program, where the alumni of GNIDSR mentored our existing students. And whenever I go anywhere and see a clinic of students, ex-students of GNIDSR, if I have time, I sometimes go there and I see in front of the clinic, they're full of chappals and slippers. Means they have so many patients. I feel so proud. It doesn't matter whether they did very well academically or not, but many of them are doing wonderful clinical job, many of them are already faculty in our college, and we are all proud of them. And also our today's guest, Dr. Professor Niladri Maiti, who did in 2014 only, he did MDS from our college under, I think, guidance of Dr. Paramita Mujumdar ma'am. And at this young age, he has become a dean of an international university, a dental college. He has done PhD there in Uzbekistan. When I was asking him that, will you call us to Uzbekistan, we can go and see around there, or call us for some upgradation. So you students who are the existing students, you can also contact him, that if you want any upgradation, anything, you can go there. And he has a wide experience of working in Iraq, Morocco, Uzbekistan, so many places he has worked, and I think he has enriched him professionally, and with his knowledge he is going to enrich us today. So I will again welcome you all to Focus 2025. Thank you all.
Thank you so much, ma'am, for your inspiring and encouraging words. Now, I would like to request our speaker, Professor Dr. Niladri Maiti, sir, to kindly come up on the stage. And I would also request our hospital superintendent, sir, Professor Dr. Soumitra Ghosh, to kindly join ma'am in felicitating our speaker with Uttariya bouquet and a memento. I would also like to request Professor Dr. Kaushik Datta, sir, to present a gift on the behalf of Alumni Association. Can we have a round of applause? Let's put our hands together for this proud moment. Thank you, dignitaries, for the warm gesture. Now, moving forward, I would like to invite to the stage the esteemed chairperson of the session, Professor Dr. Paramita Majumdar ma'am, Head of the Department of Conservative Dentistry and Endodontics at GNIDSR, actively engaged in postgraduate teaching and research. She has numerous publications in index journals and is involved with several academic and professional dental associations. Ladies and gentlemen, please join me in warmly welcoming ma'am with a big round of applause. With that, I would also like to request ma'am to introduce the speaker and invite him on stage.
Thank you, Dr. Shreya, and good morning to all. It is really very difficult to introduce our speaker because I was handed over a 4-page introduction. So very painstakingly it got trimmed to 2 pages. So please bear with me. So the person who began as Niladri is now Professor Dr. Niladri Maiti, who's a dean also. So, for a more formal introduction, he is an internationally acclaimed endodontist, researcher, and an academician whose contributions to the dental science does not span the state, the country, it actually spans continents. He began his dental education with a BDS from Rajiv Gandhi University, followed by MDS in the subject of Conservative Dentistry and Endodontics from our college, and which was under West Bengal University of Health Sciences. Later, he earned PhD in Medical Sciences from the Republic of Uzbekistan. He is currently the Professor and Dean of School of Dentistry at Central Asian University, Tashkent, and has previously served in key academic roles in Iraq and India. He is a certified dental educationist from the UK, Kazakhstan, and India. He is a dedicated mentor and academic leader with a focus on curriculum development and teacher training. He holds multiple international patents, including those from Australia, Germany, and the UK, for innovations in dental materials and laser applications. And his research bridges the gap between clinical needs and technological advancement, so he is a truly translational researcher. He has presented papers at leading international forums, including the WFLD Dubai, FDI New Delhi, and the Asia Pacific Dental Summit. His recent workshops and talks in the Maldives, Vietnam, Bangkok, and Morocco underline his global impact and expertise in laser and herbal-based endodontic treatments. He has held key leadership roles in dental accreditation, research development, and international conference organization too. His excellence has been recognized through various prestigious awards such as the 2025 Top Doctor Achievement Award from Italy, the Yorlik Honor from the Governor of Tashkent, AFCA University Best Employee Award 2023, and the Rector's Appreciation in 2022. He also received the Best Workshop Award at the Tashkent International University in 2019. Continuing his academic growth, he recently participated in Colteen Weldon's Key Opinion Leader Training and Advanced SEM workshops, demonstrating his commitment to staying at the forefront of dental innovation. So now it is time to move on to the part that we are looking forward to. I would request Dr. Niladri Maiti to take the stage and enchant with his lecture and demonstration. Thank you very much.
It's good morning. Good morning, everyone. Thank you for giving the opportunity for present my work. I would like to thank you, first of all, the administration of Guru Nanak Institute of Science and Research for the platform. You have made a wonderful progress since I left. It's a great arrangement. I'd also like to thank my mentors, my seniors, my teachers, and my professors. I have worked with them. And a lot of people are here already who have helped me, guide me during my thesis and research work, and which has given me the critical feedback, has given me a lot of fruitful effect, a fruitful result which I have achieved. I would like to thank to my professors. It was actually Professor Dr. Paramita Majumdar ma'am who initially chose my thesis topic. And 10 years down the line, I managed to take a patent of that thesis. So I thank all of you. All of your critical feedback that helped me what I am today. I currently work in Uzbekistan. It's called as the heart of Central Asia. And I'm in the capital city of Uzbekistan, which is Tashkent. This is our dental college. We have dental, medical, and all the colleges within one single campus. To start with today's topic, I was asked to keep the things very basics, very simple. So hope you all know the concept that we are changing for the fact that from BMP to CMP, that means biomechanical preparation, which was the initial concept, and we changed it to CMP, and now we call it cleaning and shaping. The transition itself, it's obvious for us to know that now we are focusing more on the cleaning and shaping. That means we are preparing a space in endo inherently which is needed for shaping and cleaning. Let me quickly scroll through these. We all know the importance of isolation. Now, out of all the factors, there are certain points which I have highlighted in bold, which I feel are the key components, which is the visibility, prevent of accidental swallowing and aspiration of foreign bodies. I know it's an extra amount of time which we spend giving the rubber dam to a patient's mouth. Of course, yes, but once you place the dam, there is a great deal of comfort that we find, and much more clinical competence can be achieved while using a dam. Of course, choice is yours whether you use different kind of dams and different kind of clamps, or you may choose to use a smart clamp. We all know about this de-roofing of the pulp chamber when we do our initial access. My humble suggestion for everyone that we have to do the de-roofing with your provided instruments that you have with the help of single mortars or burrs, or you can also use different ultrasonics to get rid of that de-roofing agent, because this is essential for all the rotary instruments to act. Now, the use of ultrasonics has evolved a lot. Now, whatever devices that you have that you are using in ultrasonics, it's up to you. You may use any kind of ultrasonics, but ultrasonic is used in all stages. Say, for example, right from the stage where you are trying to find a canal, ultrasonic has a great importance in it. And then again, refinement of the canal. And when you are trying to de-roof it, and you try to use off your burr, and you are skeptical because the remaining dental thickness is less, then that is the exact time when you should be hitting your ultrasonics. Obviously, when you are doing different kind of irrigations, ultrasonic is of great use. You can use sonics and ultrasonic both in irrigations. And of course, when you are doing surgical endodontics, root end preparation, I think that's the best tool to do the ultrasonic preparation while using the root end preparation. Tip is choice is yours. What kind of tip that you use? We all know that the importance of the access. I'm not an advocate for ninja accesses. I'm always in favor of a wide access. An access, there is no obstruction in the coronal part, which is essential for all the modern generation rotary to move freely. Now that's the thing. When we were studying, we are learning this during our times, 10 years or 15 years down the line. When we say that, yeah, either use an apex locator or you are using X-rays. X-rays are mandatory. IOP is mandatory. But I think in today's world, it should be this. You need both. This is what we should be doing. We need both, IOPA as well as an apex locator. Of course, if all act together as a conjugation acts in your clinical judgment. Yeah. If you look at this radiograph and if you look at this picture, you can see, you may look at this. Look, it's slightly outside the canal. And this is what we do, we try to adjust it. And okay, that's fine. That's the need of use of an apex locator. And when you look at the picture, look at it. Now you are adjusting the file, you are trying to taper at the end, you are trying to give a pre-bend, but once this happens, you will have a nightmare time negotiating this part. So I think it is better that at the beginning of the stage we use the apex locator and then conjugate with, correlate with a radiograph. So the accuracy of apex locators, there are different studies that advocate the accuracy of apex locator. If you look at the traditional top-notch endodontic journals, IEJ, JOE, you will see the accuracy rate is 80 to 90%, which is super good. If you look at non-endo special journals, you can also see accuracy close to 100%. But I would not be framing this because still 80 to 90% is a pretty good result. So these are the things, if you're not at the terminus, these are the things that one of the things can go wrong. One, either the canal is blocked or the file curvature doesn't replicate your canal curvature, or your diameter of the file is too wide, or the shaft part is too wide. These are the 4 ways that can go wrong, and it will prohibit you to reach to the terminus. Glide path is something very essential. I don't know how many of you follow in your daily practice, I understand, but I think glide path is the most underrated factor. I think all of us should be applying the glide path concept. It's important. So that's why I think the golden files are the size 8 and size 10 files. And most of the ledges that happens, I think that happens with size 15. So it is widely accepted now, the first file that should go is either a size 8 or a size 10. Yeah. Now, there is a paradox of choice if I say which is good, which particular file system is good. So we spend an endless time selecting a particular file system. But if you look at the treatment prognosis doesn't depend on a system of file. The treatment prognosis depends on something else, because endodontic therapy is essentially an antimicrobial therapy. Our aim is to decrease the microbial load. That has nothing to do with filing. If your filing has gone, and if you have achieved the level of disinfection to the end of the canal, it's solved. So we spend most of the time looking at different file systems. We have gold, we have blue, we have different colors. Last week I saw a file in China, 1 month back. It has blue, gold and silver in one file. Just imagine. So much time we spend with that mechanical instrument, but the fact of the matter is it doesn't alter the prognosis of the treatment. So ideally, if you are encountering a curved canal, you should be looking at the file which is more flexible. If you are not looking at a curved canal, then your choice is different. If you are looking at a double curved canal, then your choice should be different, ideally. Okay. Let's see some evidence. So this is a common thing that we do in our university clinic. We do all the time. Whenever we are using a rotary and whenever we go for an autoclaving, we actually ask all our students and all our faculty members, look at the blades. are these blades opening up? Are there any kind of distortion or damage? There is someone sitting in the autoclave room, they always see. If there is damage, they will just note that there is significant visual damage. If it is so, because all these files are actually made for one use. But at our Asian context, we can never do that because we charge way less. So basically, we are autoclaving and reusing. So someone is telling you this file is very flexible, it will go to all curves. They are right, but for the first case. After that, the thing doesn't exist. So what we're going to do is we're going to do every time we do an autoclave, we try to see the visual inspection. Is there any damage or dent to the blades? Is there any physical distortion or any sign? If there is much more distortion, then we'll sideline those files. About the single file, before we jump into our files today. So many of them, they say they're a single file system. The single file concept, if you see nowadays in today's workshop and today's different kind of conferences, the single file is again going down because there is no truly single file. So you have to use all your 10 files, then you have to do your preparation. If it doesn't match, you have to take a second file. So there is actually virtually no single file. So I hope some of you are aware of the torque and speed. The take-home message is the low torque instrument increase tactile sense and reduces the risk of instrument fracture. So most of the time, this low torque is useful for us when you are really having a curved path, when you really know that you need an increased amount of tactile sense. Speed is again, you see different files which has more speed, and you'll see different file which works on lesser speed. The ideal, we say that follow the manufacturer's instruction, because at certain speed it should have certain physical properties that should be there. But what we see is, you increase the speed, you lose the tactile sensation. You will see so many studies on files, but very less studies on motors. The motor vibrates. As it vibrates, you lose your tactile sense because now you are countering the vibration force of the motor. So someone says it has great tactile sense. Yes, it has great tactile sense, but probably your motor is vibrating way more. So now you are actually countering with the vibration of the motor rather than the canal itself. That is one of the reasons in cases where our tactile sensation fails. But there is very less number of studies if you find with the motor. So also, if you see with the highest speed, there is breakage of instruments, fluid distortion. Fluid distortion is something we can easily visualize with autoclaves, after autoclaving. Change in anatomic curvature, loss of control, and it decreases fatigue resistance. Now, irrigation has changed way more. Now, if you ask me irrigation, it's your choice. You can use a sonic irrigation, you can use ultrasonic irrigation. You don't need to buy everything. You don't need to use also lasers in everything. So if you have ultrasonic unit, just buy a tip and you can use the irrigation with your sonic irrigation. Today, we'll be using this as they are supporting us with the equipment. Today, we'll be using this. I hate to put company slide, but again, as today we are being supported by that. So most of these instruments, if you see, they speak about cavitation. Wherever you see they will create a bubble. That bubble will burst and there is cavitation. In order to understand in very simple terms, have you seen a balloon? If you try to fill it with a lot of air, the balloon bursts. So that means the energy is exceeding and it bursts. What bursts, what comes out is a form of energy, right? So it's an energy that bursts. The same thing, it's formation of a vacuole, the vacuole bursts, the energy disperses, and the waves that takes those fluid towards the dentinal canals, towards the dentinal tubules, and towards greater depth. The same concept of balloon. We all know, this is now a very common fact about smear layer removal. Not only because the irrigation goes in, I see all presentations where we see that disinfect should go inside. Yes, disinfectant should go inside, but I think in today's world, before we put calcium hydroxide within the canal, we should also use EDTA before. If you don't use EDTA before, what you are guaranteeing your calcium hydroxide is really penetrating through the smear layer inside the dental tubules? No. So these are the brief things we all know: straight line access, smooth glide path, patency, then chelators. If you use chelator, choose to use irrigate and re-irrigate, recapitulate, 8 or 10 size file always with you. Magnification, whatever magnification options you have, to start with loops. If you have a high-end endo practice, go for microscopes. Clean the flutes, be gentle, and then passive stroke. This is something, only 2 to 3 passes. If you go more than 2 to 3 passes, then you are enlarging the canal. Then the problem happens, the corresponding gutta perca doesn't fit. Then you add up doing the doomstick with so many. Okay, let's see. So if you see some studies, you'll be amazed that since we started using NITI files, the fracture of instrument had increases tenfolds. Now it is a natural question everyone would ask that, okay, if the NITI file fractures so much, why the companies are saying it is so much fracture resistant? So it fractures not because of the file. It fractures because of the associated factors. Your mortar, the curvature that you forgot, you think, no, I don't need to do ninja axis is fine. And now your rotary instrument will follow 2 or 3 different curves before it actually enters the canal. So all those factors, not cleaning or reusing many times, those are the factors that has come into play, or not following appropriate speed, or if you see there is a gouging or there is a torsional fatigue, you're still pushing it inside. Those are the reason of this fracture. Hope you know this is a different type of fractures. Either if your instrument fractures, any instrument, that rotary instrument fractures, either it can be torsional, it can be cyclic. Torsional is very simple, one end fixed. If you're pushing an instrument, the tip of the instrument fixed and it fractures, torsional. And if you cyclic fatigue, it's a different case. If it is doing repeated use through multiple curvatures, cyclic fatigue. These are some of the curved canals that you can see. These are treated, if I look at this, yeah, this was done in this college. This is one of my first curved canal, double curved canal we managed to publish. This is here in our Guru Nanak Institute, in our Department of Conservative Dentistry. If you look at this case, this is one of the oldest case of the double curve canal. I was fortunate enough to be guided by the professors to do this case. It helps a lot. Look at it. After 10 use, the tip. Now, if you want to really test a file which is really good, you have a great deal of other colleges than here. Please, after a few uses of file, take this file, give it to the metallurgy section. They would evaluate. Then only you can actually know how the really file is going well or not. This is in my university. What we're doing is, this is a tabletop SEM, small SEM. The SEM that you see is a very big one. It's for all purpose. This is a small tabletop SEM. What happens is, whenever we see a file that is fractured, we take the file, give it to them. He puts that in that lead, and within 5 minutes we get an image. So in this way, what's going to happen, we can run some small scale studies, as well as we can give our feedback to those files. So we know this file are breaking for some reason. If you want to note, it is torsional cyclic. So metallurgy people can easily give you that. Today we will be, in the hands-on, we will be using the NeoFlex files. NeoFlex, I think, pretty similar to the files that we have used. We have orifice shaper, glide path, and for narrow and medium canal, different pathways. We have this 4 to 6% taper variation. I think pretty simple, gold-plated file, triangular cross-section. They also have this, which we will not be using today, with this S-shaped cross-section, which is called Neoendo S, as well as the Neoendo Blue. Again, we will only be using the flex. This is the blue color. This is the triangular cross section. As you know, the blue color coating now is used for enhanced cutting efficiency and flexibility. I don't know how many of you use the TCA technique. Whenever you get a canal, we were always told that the rotary instrument should go in a motion inside. When it comes out, it should be. But you may beg to differ in some cases. And this is already published in JOE in 2017 if you look. Now if you have a really double curved canal, if you choose a file which has very superior fracture resistance, very high, it may not have good cutting efficiency, but fracture resistance is super high. You may choose to go to the first curve, as you see in A, and then start your rotary. And the moment you enter 1 to 2 millimeter, you stop, you come out. That's it. So you go 1 millimeter, 2 millimeter, that's it. Now like this way, you will try to reach the terminus. But it violates the very theories that we learned that it should go in a motion and comes out in a motion. But also we cannot deny that now it is in JOE. So in some cases, in extreme curve cases, or if you have an option to choose certain kind of files which has extreme high fracture resistance, you may try this with caution. Again, these are all done with TCA, extreme curvatures. But it took way longer time. Again, TCA. TCA, okay. So there are a ton of files that you see, white, blue, gold, and as I mentioned, you saw a file which has 3 colors in one. So the choice is yours. What kind of file that you are choosing, what kind of clinical practices do you have, more endo-based practice, what kind of endo practice, or you are doing referral treatment, more retreatment cases. So choose wisely. To quickly sum up, we will try to finish as fast as possible. Whenever you are irrigating, we need to see these bubbles. If you are not seeing these bubbles, something is wrong, because our hypochlorite is supposed to have flucloridine. That should be released. If you don't see it, something is wrong. Change the solution. Okay? You should be seeing these bubbles. So we are mostly focused more on the mechanical side, but ideally we should be focused more on the right-hand side. Okay. So we have penetration of files. I don't know how many of you use the side vented needle, but study shows that if use, this has the highest efficacy. The side ported needle, followed by this vented needle. This is a vent, and this is a port. So these has the highest efficacy. If you look at different studies in JOE and IUJ, followed by these. If you have a choice, if you have an option to use a syringe warmer, then you can actually use the same solution rather than replacing it, because you know the degree rise in temperature increase the efficacy. So its choice is yours. If you have a syringe warmer some way, then you can use it. If you don't have a syringe warmer, still ultrasonic is good, because ultrasonic transmits energy. Whenever there is energy, the temperature rises up. Okay. Whenever you have a bottle of water which is say 8 degrees, put it in a mixer. The water does in a vortex. Touch it. It is not 8 degrees. The temperature will rise. Friction between the molecules. So most of the time we are using sodium hypochlorite. Hydrogen peroxide is, I think, no longer used in most of the places, banned in some countries. Clohexidine is slowly getting reduced, the use of clohexidine. You will see endless studies in JOE and IJ that clohexidine is found to be more toxic. We still use it, but the toxicity of clohexidine is now increasing. There are more of studies. So this is the Zender's protocol. I think we all follow it. They have a broad spectrum antimicrobial spectrum to efficacy against anaerobes and facultative microorganisms. Choice is yours. In some cases, we managed to give a bacterial culture, a swab culture. In some cases, ideally we should be doing in all cases, but as we're in Asian context, handling huge number of patients, But in some cases, we managed to give it to the culture. And it should dissolve necrotic pulp tissue remnants that only sodium hypochlorite can do, because we know that EDTA and any other product, even citric acid, doesn't have the tissue dissolving property. So for the smear layer, of course, we need to rely on the EDTA. So any irrigant that you use should be non-toxic, not caustic to periodontal tissues. Whenever you have open apex cases, then you should be very careful, because there is a great deal of debate that what kind of hypochlorite should be using open apex cases. Ideally, if you have a negative pressure technique like EndoVac, somehow you can manage. But if you don't have a negative pressure technique, which is considered to be gold standard, then you will have an issue. Now, if you look at it, most of the time it is concentration of hypochlorite, but especially if you're handling retreatment cases. But it is also says the duration on interaction. That means how long the hypochlorite is inside the canal. So ideally, if your canal is wet, from start of the preparation to end, that is the duration of time your hypochlorite should be staying inside. So that means if you're rinsing for a few seconds and taking out, that's not enough. Most of the time, whenever we're using, the reason I'm advocating to use at least ultrasonics or some form of sonic is because at the apical third, there is no exchange of irrigants. That means there is no disinfection activities happening there. So that is something that you should be careful about, especially if you're handling with something that assists that you expect that in few months it should recess, and then your irrigants, your antimicrobial activity has no effect there. So that's the reason I generally advocate to use some form of activation or agitation. So if you look at these old studies that says that Enterococcus faecalis, Candida albicans, all those part of this biofilm needs this minimal amount of time of 30 seconds for 5%. But we don't use a 5.25% hypochlorite. Or when your hypochlorite is staying in a place, it loses its efficacy. Okay, let's take the temperature. Again, as I mentioned, if you have an option to increase the temperature of your irrigant, go ahead. This is something that I was speaking with you guys, that if you see there are huge number of studies on different kind of irrigation, huge number of studies in IES, IJ and as well as JOE. There is still, this is 2022, okay, till date stays. This says that there is no consensus on optimal concentration of sodium hypochlorite. That means we know what is the best percentage of sodium hypochlorite, but they haven't reached a consensus. Like the endodontic consensus, British endodontic consensus, ideally they should give a consensus statement. They haven't given. And in the same study, in the same paper, they says chlorhexidine is equally or more cytotoxic than sodium hypochlorite. This is the reason of worry, because now there are more studies coming up. So we should be really worried if we have a, if we are not sure about the constriction or not sure that we will be able to tackle the solution within the canal. We all use in some cases of calcium hydroxide medicaments, which is the most popular use. I'm sure that you are not using, but we do use antibiotic paste. We have some ready-made material of antibiotic paste. While removing calcium hydroxide, I think ultrasonic has the best role there. Otherwise, if you try to remove calcium hydroxide, it is an oily base. It needs some form of agitation. It needs some form of detergent action. Otherwise, you are never removing calcium hydroxide from the canal. Some layer still stays. Now again, obturation, we all know up to where, up to the level of cemento-dentinal junction, you should be obturating, with the fact that what are the factors when you are using obturation? Ideal, that this is the point where after obturating a negative culture test, but I think in a heavy practice, you will not able to do this. So you are totally reliant on the clinical sign and symptoms. We now use bioceramic sealers. Why? Because ideal bioceramic sealers, some of them are supposed to expand. So if you are using a single cone technique and it expands, it helps. Rather than you putting endless, making the broomstick appearance, but putting endless amount of pressure on the lateral walls, and then after some time the crown fractures, you have put that pressure there. Cases like these, resorption, I think bioceramic sealers have great use in resorption, because whenever there are cases of resorption, you want some of the bone generation or dentin generation activity. If you use a true bioceramic sealer, I think this is ideal situation when you are using resorption. We have dealt with some resorption, we never had access to bioceramic sealer, now we have. So we have done some cases where we see it has good effect. Especially we know that bioceramic sealers have effect of, they can induce bone repair. Especially there is a through and through effect where the dentin is completely damaged. These are the things that you can see, the lateral callus and isthmus are widely filled, again with bioceramic sealers. Again, ultrasonic assignation with bioceramic sealers filling, single cone. All single cone. We made sure that from the manufacturer we asked that, do you have a specific study that you are saying it will expand, right? Because if there is too much of resin component, resin will shrink. But I don't need that. I need something that has slight expansion, so that I don't have to put endless number of accessories. To end with, we have few things like this is one of these. This is just July 2025 GOE, just this month. If you look at it, that most of the bioceramic seal are associated with lower post-operative pain. So this is also something. We are looking at bioceramic sealer healing, I understand, healing, bone regeneration, but also those post-operative flare-ups. This is a very good indicator for us. Slowly we need to look into it, because they say that if they use this compared to that of traditional sealers, now the post-operative pain. So that means, is there something that is related to the periodontal fibers, connecting with the periodontal fibers? Maybe this is the scope of the future study. Again, if you look at this, radiographic failure and non-surgical endodontic treatment and retreatment using single cone technique. Look at the conclusion they have found. This is June 2024 GOE. So it says that single cone obturation technique with a bioceramic seal provides similar result compared to that of any other obturation material technique, also facilitating healing of apical periodontitis. So now endless studies that promote the single cone technique. Yes, you need to choose a sealant that slightly expands. Okay, so this is also again, if you see July 2025, okay, this month, GOE, but it says that this is the limitations of the study. If you use ultrasonic irrigation or a combination of two irrigants, it helps and promotes the healing. So we are choosing, now we are going in the right direction, that if you use really those two forms of irrigation, it helps in the healing process. This is the latest literature. I would like to end quickly. Yeah, if you ever visit Uzbekistan, this is in summer and this is in winter. December, January, February, rest of the year. If you ever choose to visit there, visit our university, visit our departments, faculty, please feel happy to connect with me. I'm always happy to assist you, help you, guide you to the guided tour there, to the city as well as to my university. Last but not the least, yes, there is no elevator to success. You have to take the stairs. You should be ready. Some of my mentors once told me, never kill the student inside you. That helped me a lot. Keep learning, keep updating all the time. Don't look at someone as a lower age of not studying. Because I still study in today's world. I enrolled for one more master program. You'll see me are getting another master's in next 1 year probably. So I keep educating, keep studying myself. This is a lifelong venture. Never stop studying. Never stop re-educating yourself. Thank you.
Thank you so much, Professor Dr. Niladri Maiti, sir, for your insightful session and for sharing your invaluable knowledge and clinical expertise with us today. With this, I would like to request our chairperson, Professor Dr. Paramita Majumdar ma'am, to kindly felicitate our speaker with a certificate of appreciation. Now, I would like to request Professor Dr. Rudra Prasad Chatterjee, sir, the Executive Committee member of the Alumni Association, to felicitate our chairperson, Professor Dr. Paramita Majumdar ma'am. Can we hear a hearty round of applause from the audience? Thank you, sir. Thank you, ma'am. So anybody from the audience, if you have any questions, you can ask the speaker while we still have him on the stage. Anybody who's doing the hands-on program? Okay, so we are closing the session. Thank you, sir. We'll just take 10 minutes to prepare the stage for the demonstration. Bear with us for the 10 minutes.
Hello. Hello. Yeah. So today we'll be starting our demonstration for Neoendo Flex file. Then, okay. So we have a upper molar tooth. Let's see. So by default, whenever we have a upper molar tooth, or any tooth as a matter of fact, when you have access preparation done, ideally you should be looking for the complete refinement of the canal. Let us first inspect the particular canals, okay? So if we try to choose today that we'll go for the palatal one, which is supposed to be the wider one, let's see. That's the palatal one, okay? This, to me, it is pretty much viable and patent canal. Yes. Try to observe the file. As a matter of fact, if there is any niche, if there is any bend, if there is any curvature that you are determining through the files. Once you are done with this, once you are done with the access cavity refining and site to see with the size 10 file, you may choose to enlarge the orifice, or if you have a lot of space, you can also, at this initial stage only, you can choose to have determine or cross clarify with your working length through the help of the apex locator. Ideally, in a live condition, it should be beeping you, giving the proper readings. As it is not a live condition, so we'll assume this is our working length. Okay. Yeah. You may choose to use the reference from your nearby or the most adjacent cusps. Be sure to look at any kind of accretion or any kind of surface defects of your reference cusps. Let's try to go ahead with your orifice enlarger, but before that, it's essential that you have a glide path. So if you ideally have any kind of glide path file, make sure that you run through it through the terminus to make sure that your canal is now patent. Can I have the endomotor thing? Can I have the endomotor? This is. Yeah, we need the normal one. No, we don't need the reciprocation. We can use many files are there. You may choose to have a reciprocal mode or choose to have a rotational mode. But at this file, I would prefer to use a rotation rather than a reciprocation. However, studies suggest that if you choose to do a reciprocation mode, your chances of apical extrusion is less compared to that of rotational mode. And if you compare rotation reciprocation with hand instrument, then the chances of extrusion is far more in hand than in rotation and reciprocation combined. Yeah. If you look at it, have you seen? So I can make out a small flaw that the centering ability is not that great. It's definitely not the file, it's the motor, maybe the repeated use of motor. Be careful when you have this bobbling effect. If you still follow that your instrument should be running throughout with on mode, and then you should be very careful because it is not absolute in its centering ability. So 2 to 3 strokes. I previously added some liquid. Ideally, you should be using sodium hypochlorite in the canal all point of time. So I'll add some more. That's it. Always try to cross-verify that whether the working length that you have achieved, it's there. You have not produced any kind of ledges, any niches inside the root canal walls. As we see here, whatever we have achieved, we're still there. There is no loss. You can still use to have a more well-defined orifice opening. As you can see, I can use only 2 to 3 pecks. That's it. Now, some of the users, they recommend you to give a brush stroke. Okay, to give a brush stroke in the canal. It's your choice whether you use the brush stroke. If your file is really at its topmost centering ability, then it's fine. If it is not, then be careful when you use these brush strokes, because if it is not at its perfect centering ability while we're doing those brush strokes, it may dent or niche on the adjacent canal. So, do you have a chip blower or something? Anything to rinse off? Any chip blower or anything to take this water? Anything? Let me see. No, I can do that. No, it's okay. Thank you. While doing the access, I would always highly suggest everyone to use either loops or microscope. I mean, these loops are great with only 70 grams of weight and very high lux intensity weight. So you may use a loop to have a more predefined and greater control over your instruments. Yeah. If you look carefully, if you observe at the access cavity, at a certain point, as we say that we need a straight line access, all the instruments will go, but I can still see a part of dentin shelf, which is not a problem because we are choosing a larger diameter of canal. But if it had been a smaller diameter of canal, we would ideally need to have some more refinement, either with the use of some burrs or ultrasonics. So as we see, we have used this, and the next file, next sequence we'll be using the glide path file, which is the 4% and size 17. Okay. Again, I don't know whether it's visible. Two to three strokes. This is size 17, almost mimics the use of a size 15 file. But then again, it's a glide path file, so it's much more flexible. If you look at those files, so it doesn't have that great shape memory, but it still has some sort of shape memory if you can look at it. So then again, you have to know that it will take the shape of the canal to some extent, but eventually when the thing hits up in the canal, the body temperature rises, it will again come back to its main position. Let's see again. One, two, and the third stroke. Three strokes. This is enough. Again. Oh, okay. No problem. At all point of time, keep checking with your size 10 file that whether there is a loss of working length, or during this rotary preparation you have done some accidental ledges. No, we are still okay. As you know, this file, if you want to choose, some of the files has a single ring, some of them have a double ring. So this is a way you can choose the taper. The single rings are generally 4% taper and the double rings are generally 6% taper. It's a choice what point of taper you want to use. Make sure that you have the corresponding gataperka as well as the tooth that you are preparing. At no point of time we can stop at size 20. So ideal situation, you should be going at least size 25, which is the least, or if required at size 30, but ideally never less than size 25. Let's see the shape memory of the canal, not that. Yeah. Very flexible, not that shape memory, that's fine. When you use a particular rotary instrument, now there are so many, as you see this is gold coated, okay? So there are blue colors, which is the Neoendo blue, there is S shape. So be careful and try to look at the surface, try to look at the metallurgy of the file when you try to choose and use it. I've done 3 passes, let's see. Again. Done. Okay, 3 passes. Irrigate. Take your 10 file, agitate. There are ways of irrigation is either you can irrigate at the final stage, but if you do have a sonic irrigator, you can start using once you grow close to 20. After that, you can try using a sonic irrigation. it will help removing the dirt and removing any type of thing that is clogging towards the terminus. It will help removing those. On? Okay. Okay. I can use it, right? Done. Again, check. Because now we are preparing, we need to get way more irrigant than before. We'll increase the size now, which is the red color, which is still in the 4% taper. We are using a single ring 4% taper. Yes, okay. Again, try to look at the file. It doesn't have a shape memory. Now, when you are inside the canal, you may choose some strokes. One is the peaking motion stroke. When you peak this and you come out, peaking motion stroke. And generally what we practice is when we come out of the canal, well, not going inside, but when you're coming outside of the canal, you brush it against the walls. So when you are going again inside, you are peaking inside, and when you are coming out, we are just brushing against the walls, hoping that this particular file has a maximum contact area with the walls, with the dentinal walls. If you look at the centering, centering is really not that great. So be careful when you are putting it inside the root canal, especially when your orifice is not enlarged. Yeah. One motion, 2, 3. Stop. Let's irrigate and check. I hope you have already seen that I don't use EDTA, the EDTA gel that much, and explain you the reason when we do the hands-on. So, okay. At all point of time, please keep checking this with size 8 or size 10 file. Let's use your ultrasonic irrigation. Now we'll get to its full cycle because we have enlarged. Make sure you touch all the walls. Let's take our instrument again and try to have the same peaking motion. Now we shifted to the two ring. If you look at it, it has two rings. The file has two rings. The two rings stands for a 6% taper. Do you have a gutta percha for the 6%? Yes. Let it irrigate. Make sure in between each steps, you try to observe those files. And if you look at it, it's really clogged, and please keep cleaning those files in between. The flute should be really clean, because the flutes are the places when the material is loading it up. If it is really full, then it can easily have a fracture because of the taper lock. Yeah, we didn't lose the working length so far. Again. One. Please keep checking that whether we have lost the working length or not. Do you have the gatapacha? Do you have the gatapacha for this? Yeah. It will be 26% if you have. ঠিক আছে দেখুন একটা দেখো যদি কোনো ম্যাচ করছে can use it. So 4 আছে তাই তো 25.4 now 25.4 let's see if it works. হয়ে যাবে হিট প্লাগারটা আছে হিট প্লাগার ইয়েস সিলার কিছু আছে ডু ইউ হ্যাভ এ সিলার এনি সিলার okay that's fine. Make sure you choose rationally about the choice of your sealer that you're using. As I mentioned you that if you choose to do single cone, it is always wise to use an expandable sealer. That's all. Touch. Okay, it's okay. So we've done it. You can see it's fantastic instrument actually. Works as a great GP cutter and also the plugger. It's super. We are done. So before you inspect, ideally, if you look at it, the obturation, what we have done, is ideally the obturating material should be at the level of cemento-dentinal junction. So if you have excessive amount of gutta-perca or excessive amount of sealer, please do remove it from the surface and make sure we're only up till the orifice. It will help the other restorative treatment procedure which you are following either in restorative or a crown. So, yeah. Can they visualize this one? The camera, the inside? Inside, can they see? Okay. As you can see, please clean as much as possible. If you're using a sealer, make sure the inset surface is as clean as possible. And if you are using a sealer which sets in a longer duration of time, then probably you still need to wait for some time for the setting time, the initial set to be over, then to clean it. and followed by your interim restoration or temporary restoration, depending on what are the next treatment protocol that you are following, restoration or a crown. So we'll learn more during our hands-on session when you people will be doing this, and come up with all your queries. Thank you. File is good. Good file. It's very good. This instrument is superb when I use it. It's really good. I mean, I think it is great not only for irrigation, but if you are having this calcium hydroxide removal from the tool, it really works. It's really portable. And you also during the retrieval time, it helps a lot. Thank you.
Thank you so much, sir, for the wonderful demonstration session. Those who have registered for the hands-on program, you guys are requested to collect your lunch from the gymnasium room, and we'll again meet after 30 minutes for the hands-on session. Thank you. We are ending the live session now.